Thank you very much. I would like to extend my gratitude to Dr. Sparia and Patakos for their kind invitation and to talk about a subject that is really interesting in my views. So when we are talking about successful implantation, what are we really talking about? Because if we see from the VARC3 criteria, if we say that we're going to talk about technical success, so it's just to implant one valve, the valve will work properly and we will have no freedom from surgery or intervention related to the device. But if we're going to talk about lifetime management, then we have to consider all these different aspects because in my view, this is a successful implantation. It's just not placing a valve correctly, but also to have no PVL, to have low rates of permanent pacemaker. So this is something that we must talk regarding a successful implantation. So this is where it all started in Rouen in 2002. And just for the history, they had only one valve, one available size, and only one valve available for this procedure. So what we have learned from 2002 is that we have a lot of data. We have many clinical trials. We have a lot of patients that have received this kind of therapy. And this has led to the revision of the guidelines 3 times in the last years. So now we are talking about the age of the patients, that above 75, we should have a TAVI and not surgery. And we have left behind us the surgical risk. But what we have in this, all of these years is that we have the available devices, they are evolving, and we have now the 4th or 5th generation in some kind of devices. But what we don't have all these years are head-to-head comparisons between the different devices. So if you're trying to say which device is better and which valve I should choose for my patient, we do not have head-to-head comparison. There are only 7. The last one is the landmark that we will see the results in the following week in EuroPCR. But we have seen from these studies that in some cases we had non-inferiority reached, but in some cases we did not. What is very interesting for me is that if we take the scope 1 did not meet the non-inferiority, so the valve was inferior regarding the SAPIEN, is that when they published the 3 years result, we saw that they had not any clinical significance. So the initial results in the 3 years, we did not have any difference between the people that received those 2 valves. So what we have known so far is that if we're going to consider lifetime management, we have to talk about PVL, about AV conduction disturbances, and coronary access. And what we don't know, because all these factors were not included in the randomized controlled trials, that we do not have enough data for bicuspid, we do not have enough data for multivalve disease, for severe CAD. So this we do not know. So if we're talking about some patients that actually have this, my answer, which is the proper valve, is we actually do not know what to do in this kind of cases. So all existing valve designs, they have strengths and weakness, and let's try to explore. What is very important, and I think that is the most important thing concerning when implanting a TAVI valve, is that the first valve matters. Because if we're thinking about lifetime management, you have to put a valve that will work properly for, let's say, 10 years, but then you will be able to implant a second valve if needed. So the first valve matters. And if we're talking about durability, from the US we have data, and they suggest that if there is a 62-year-old person that has to have a valve procedure, the valve must last for 20 years. So we do not have data for this, but the Americans say that if you're going to implant a valve at a 77-year-old patient, the valve should last 10 years. So this is something that we really must take into consideration, choosing the valve we're thinking. And why do we do this? Because we have now known that the age of patients receiving TAVI devices are getting lower. So in the US, there are people 65 years of age that have a TAVI procedure. So for these patients, we should be very careful about lifetime management. And what do we know? The notion, the 10 years trial, is that the difference between the surgical and the TAVI devices, they were similar. I would like to be honest with the cardiothoracic surgeons, because they are part of the heart team, that if someone looks at this study, they have to say that, okay, but you are actually comparing a TAVI device with surgical valves, but there are some valves that were implanted in these patients, the trifecta and the mitral flow, that are not in use now. So you're actually comparing something that we saw that it doesn't work. So if we're going to be honest, it's not our fault, because at that time the mitral flow and the trifecta were very good valves, but this is what we're comparing to them, with two devices that are not now in the market. But if we're going to pass this and see that despite this, if we're just considering the structural valve deterioration, in 10 years, the valve, the TAVI valve, works. So if we're not going to compare with something that it doesn't work, our valve, the TAVI valve, actually works, and the hemodynamics are very good. So what do we know is that if we're going for lower patients, we have data that the TAVI valves are compared to surgical valves in 3 years, they actually work. And what we're now thinking, and I'm going to skip this, is that there are some particular conditions that we must take into consideration. The first is the small annulus, because in the small annulus, you have to choose between a self-expanding valve and a balloon expanding valve. And the data so far suggests that when you go small, you must choose a self-expandable valve, because you have better hemodynamics after the implantation. And comparing the 4 valves, SAPIEN 3, Accurate Neo, Evolut R, and Evolut Pro, you can see that regarding paravalvular regurgitation, the balloon expandable valves are better, but if you're going to see the hemodynamics, and regarding the small and the large annulus, the self-expanding valve and the Evolut platform is better than the balloon expandable valve. And we also have data from this TAVI Small 2 registry that we know that with the paravalvular leak, the balloon expandable is better, but concerning hemodynamics, self-expandable and especially the Evolut platform is better. These are also studies that shows us this. I'm going to move on, and I'm going just to see about this concerning small annuli, that you see that actually the mid gradient is better with the Evolut system. And sometimes you have to refer the patient to the cardiothoracic surgeon. This is a patient from our hospital. So she was a very small woman, 78 years of age. And when we did the CT, we saw that the annulus was 16.2 and the LVOT was 15.4. So we had a heart team discussion. We also included in the family of the patient and said that if we're going to do this, we can implant a valve, a self-expandable valve, but the hemodynamics, because they were going to be very small, wouldn't be good. And if she required the second valve, then it will be difficult for her patient. So we referred her to a cardiothoracic surgeon. She performed an aortic root enlargement, and the patient now is doing well with this. So not all patients, and if we're thinking about selecting the proper valve for the successful implantations, some people should not get a TAVI platform. So this is the study that was published recently concerning small aortic annulus. So because it was small aortic annulus, 77% were female, and what this showed us is that hemodynamically, and I'm going to this, the hemodynamics in the self-expanding, it was better than for the balloon expandable. So these are concerning all the SAPIEN, SAPIEN XT, SAPIEN 3 core valve and Evolut system, that hemodynamics really are good in both, but in the self-expanding are better. The paravalvular regurgitation has gone down going through the ages, but the balloon expandable devices are better. And if we're going to summarize this, if we have an LVOT calcification, if we have eccentric calcified annulus, the risk of rupture with the balloon expandable valves is bigger than the self. If we have small annulus size, we can go with self-expanding. And for life expectancy, we have the notion that's the self-expandable valve, but for the balloon, we do not have data for 10 years. For permanent pacemakers, we know from the beginning that with the Evolut platform, the rates had 2 digits, about 20, but now they are moving on with the different techniques that we have implemented, CASP overlap. The digits now are 1 digit permanent pacemaker rate. So this is something that we should be considered regarding if the patient has a pacemaker. It makes our life much more simpler. I'm finishing. So the last thing and most important is coronary access after TAVI. If we're going to do a TAVI in a 75-year-old patient, we must be able to recanalize the coronary ostia. So this is the different frames that are available in the Greek market concerning with the aortic root. So we must know all these characteristics because, as Dr. Benetos explained in the CT, with the CT we can see this. We can see the different frames and how they work. I will show you 3 cases from our cath lab because we are trying to cannulate the coronary ostia just to have some expertise if needed. So I will go on, and this is very important and we must also take into consideration. The different frames, they are different. Some are more convenient in order to recannulize. If we're talking about balloon expandable valves, the majority, the coronary ostia will be up, so it's doing a normal coronary angiography. If you have a very tall frame, then you should consider, according to the anatomy, which device is suitable for your patient. So you must also know about the ceiling skirt height, because if you know about the coronary ostia, you will be able to see which, I'm finished, sorry. So these are the 3 cases from our lab. It's the different. The first one is it was a surgical valve. We implanted a core valve, and this is the result. We were able to cannulate. The second is a Navitor. The third is Allegra. You can cannulate the coronary ostia. There are some techniques, and this is an Edwards in a TAVI procedure. We were not able to fully cannulate, but you can see that the coronary arteries are patent. We must do this, and we must cannulate the coronary ostia because in year 7 after TAVI, about 17% of our patients will require some kind of cannulation. There is data, but we have problems, and we have problems with the self-expanding platforms. So this is, I will go on quickly. You have more door-to-balloon time, more contrast, more fluoroscopy time, and about 8% of the patients we cannot recannulate. So these are 3 studies, Reaccess, Align, and CAVIT. You can see that with the Evolut system, there is a problem. With the balloon expandable devices, there isn't such problems. These are all studies that are from Tarantini. I will move on to my last slides. I'm sorry for this. So we have patient-related and TAVI-related if we're going to re-access the coronaries after TAVI procedure. And finally, because the first valve matters, think if you have a low frame, you can put a second low frame, but if you have a high frame, consider having to cannulate this coronary ostia between 2 high frames. This is very difficult. And they have, each valve has, based on Kromm, there are some kinds. What will help us is 3D printing. FEOPS, Dr. Benetos already talked about this. There's also DASI. It's a similar algorithm that allows you to see exactly how your valve will function and if you have any problems. And finally, for me, each candidate for SAVR or TAVI should have a CT scan because the patients already having a surgical aortic valve, we have to know the CT if we're going to do a second operation on them. The choice of the valve should be the heart team decision. First valve matters. When implanting the first valve, keep in mind the second, and a TAVI program should be familiar with at least 2 different devices. Thank you very much.
Very detailed analysis. Thank you very much. Indeed, we're very fortunate to have many valves, but we're still unfortunate we don't have many years of follow-up. Any comments from the panel?
Congratulations, Adonis. Just a short comment. I think if I'm trying to do a guess in 10 or 20 years, I think the major valves will look very similar to each other because they all try to combine the advantages that we are looking for. So at the end, I can hardly find a way that it will not look similar to each other, the future valves.
For me, the thing is that regarding coronary access is that balloon expandable valves have a certain pro against the self-expanding valve. It's not very easy. Sometimes it's impossible. The studies have shown about 8% we cannot cannulate the coronary ostia. So 8% is, for me, is very high, because if we're talking about an 85, 89-year-old patient, he may probably never need a coronary angiography after a TAVI procedure. But a 75-year-old and he has a STEMI, and we say to him, okay, you had a TAVI procedure, but now for the STEMI, I don't know which is the culprit lesion and what should I do? So this is certainly a problem.
So the first valve matters when you have to do with a 70-year-old patient. When
Yes.
you have to do with a 92 lady, maybe
It's
not-
different. It's different. But regarding the coronary ostia, balloon expandable valves have a certain advantage. This is for sure.
As we know, the paravalvular link is less now. In a case of a small annulus, it's better to choose self-expandable in order to...
Yes, in small annulus, we have the study now that shows us that the self-expandable platforms are better in small annuli. You have better hemodynamics, and this maybe in the future will translate in better lifetime management. So we do not know this for sure. We are thinking that if we have better hemodynamics in 5-10 years, we will not have a structural valve deterioration. So the valve will function more properly. So this is because if you have a small annuli, the valve may not be fully deployed, so this creates any problem, because it depends on how the leaflets are actually opening. So if you have a valve that has not fully deployed, the leaflets might have a small, let's say, overhanging between them, because the valve is not fully deployed. So this may cause any problems, but we will know this in 5 to 7 years.
In this case, if we have a high grade of calcium, in this case, it's better to use balloon expandable.
Yes, but it depends how much calcium, because the possibility of rupture in the annulus is bigger with the balloon expandable device. So it's pros and cons. The CT will guide us through this.
Any question from the audience? No? Thank you very much.